hovering in the low 80s, and right now he's in the mid to high 90s, like around 94, 95, and even a couple of times he went up to 97%. I changed that dressing and repacked him. He's still, despite us having that tube in decent position, he's still going to leak some air out of that hole. It's almost impossible to get it completely sealed off. Um, Despite the fact that he looks better, I don't want to get overwhelmingly optimistic. I mean, he looks certainly much better than what he did last night, and even when I saw him when you guys were there. That being said, I'm still concerned about that lung. There's something going on. Again, it's probably either pneumonia or ARDS. And with both of those, you just provide supportive therapy, meaning antibiotics, keep patients on the breathing machine, try to minimize how much fluid the patient is getting, and just try to ride it out. Okay, he's on a pretty substantial amount of ventilatory support. He's getting 100% oxygen right now. The good thing at this juncture is that now his oxygen saturation, at least on the probe that he has on his finger, is above 90%. Now, in about an hour and a half or so, we'll get a repeat ABG. That's where they draw blood from your arterial system to get more detailed information about how well oxygen and carbon dioxide are being exchanged. And I mentioned to you earlier about the acid-base balance. When you have either a bad infection where your tissues aren't getting adequate amount of oxygen, you can have an acidosis, and that's called a metabolic acidosis. If your breathing system, if you're not exchanging oxygen and carbon dioxide properly, you can also get an acidosis called a respiratory acidosis. And it looks like he has a respiratory acidosis, which means that the ability to exchange oxygen and carbon dioxide is just not enough. And so we'll see with the repeat ABG, arterial blood gas, whether or not there's any improvement, okay? And so that's where we are at this juncture. I wanted to take him to the operating room to take a look with the scope, try to play around with the stent, putting another stent in place, but with him being on the continuous dialysis, there's no way we could safely get him to the operating room. Just with the continuous dialysis and the amount of support that he is depending upon from the breathing machine. Normally when we transport patients to the operating room, the amount of support they get in terms of the force by which air is put into their respiratory system, that decreases a little bit. And I think it would be dangerous to just try to transport him from the ICU to the operating room. I've seen situations where patients have either coded and died, or coded and had to have been resuscitated, or nearly coded just with transport from the ICU to the operating room. And since he's stable now, I don't want to force the issue. Okay. As I mentioned a few moments ago, right now he's in kidney failure, he's in respiratory failure. His heart function, he is requiring some blood pressure medication. I think that's probably due to the acidosis. I would expect that to improve once the acidosis is corrected. If we get into a situation where his kidneys are in failure and we're maxed out on the breathing machine support, and we're maxed out on his medication to support his blood pressure, I cannot tell you what to do, but from my experience and also studies looking at thousands of patients over several years, the mortality rate is greater than 99%, meaning in the hospital mortality rate. And we really need to take that under consideration in that circumstance. And one of the side effects of having that blood pressure medication maxed out is, at that point, the body is only going to preserve the vital organs, namely the heart and the brain. The intestinal tract, blood flow is going to be diverted from there, and patients are kind of at a setup for developing what we call ischemic gut, where the blood flow to the intestines is not there, and it kind of creates a vicious cycle. The acidosis gets markedly worse, even worse than what you have with the respiratory acidosis. And that is, when that happens, it's pretty much, it's not recoverable. Okay. We're not there yet, but if I feel, based upon my clinical assessment, that we're at that point, I'm going to be open and honest with you. And you know, if I were sitting where you were, where you're sitting right now, I would want the same. And so that's kind of my approach. You know?
He's not in any pain.
No, ma'am. He is on. He is deeply sedated with a sedating agent. He also has pain medication, and we have him paralyzed. We have him paralyzed because it's easier for us to, or for the machine to ventilate. When the patients are not paralyzed, even if they're sedated, they can sometimes try to breathe on their own, even though they're deeply sedated, and that can kind of compete with the machine and make it breathing for them more problematic.
Thank you.
Any questions?
Thank you.
Okay,
Thanks for everything you do.
that's what we're here for. That's
You
what,
say that every time, but you still want to.
that's what we do.
You guys have been amazing.
Well, I
Thank
appreciate
you,
it.
guys.